So what's the technology and what's the role? So here are my disclosures. So if we talk about, let's just group this into catheter-directed thrombolysis. So there's standard catheter-directed thrombolysis, and there's ultrasound accelerated. It's also known as ultrasound enhanced catheter-directed thrombolysis, also known as acoustic pulse thrombolysis. And you'll see a lot of these terms used interchangeably. And really what it's using is it's using the EKOS device. So just sort of to give you an idea, many of you have seen the commercially available products, but I've actually been involved with the development of this device since the late 90s. So what ultrasound accelerated thrombolysis does is you're applying ultrasound energy through a catheter, and that is not a mechanical device, but what it does is it results in separation of the fibrin, and then the whole idea is it allows a deeper penetration of the thrombolytic. So if you put the ultrasound on and you just use saline, you don't get mechanical disruption of the clot. You will get separation of the fibrin, but then saline is not active in getting any thrombolysis, so you need to use a thrombolytic. And here, this was basic early work that was done, basically seeing that when you didn't use ultrasound and when you used ultrasound, basically at multiple measurements, you had more TPA embedded in the thrombus. So this is actually the first device that I used, which was the PT-1 system. It worked with a laptop and a very rudimentary generator and a catheter basically that had a single filament at the end, of a single ultrasound transducer rather, and the similar guide wire port and also coolant. Then there was evolution of the device, and what you can see here, this is basically a electron micrograph showing what that low energy, high frequency ultrasound does. And then they came up with the multi-element catheter, which actually had 5 centimeters of transducers, and you would be in the lab. So we talk about on-table solutions. You're going to hear about mechanical thrombectomy in a minute. You'd be in the lab, and you actually would turn the device on, and then you'd have to remove it and pull it back, 5 centimeters to treat a whole 10-centimeter zone. So this was really very rudimentary. This is what most of you have seen. If you've seen it, it's basically the current EKOS device. It's a 5.4 French catheter. They have ultrasound transducers going from 6 all the way to 50 centimeters in length, and a lot of times when you're treating DVT, you're going to end up using that 50 centimeter long catheter, and it comes in 2 lengths, 106 and 135. The device was actually approved in 2004 to be used in peripheral vasculature, arteries, and veins. And so a standard for treating DVT, this is sort of a standard protocol, one access, either popliteal vein, my preference is tibial vein most of the time. You do a venogram, you put in a 6 French sheath is good enough, and then an EKOS device, and you'll use TPA anywhere from a half to a milligram an hour. Low dose heparin, you need to use coolant because the device does generate heat. And that's typically at about 35 cc's an hour. And then usually when you're doing catheter-directed thrombolysis, you're going to do a catheter check at anywhere usually between 16 and 24 hours. And theoretically, and also in a lot of people's practice, and the literature I'll show you in a minute is kind of all over the place. But the whole idea of using ultrasound and over standard catheter-directed thrombolysis is it can be more efficient. You're using less lytic, lower doses, always equals less potential bleeding complications, as opposed to what has been seen, at least in a lot of the literature, with longer infusion times when you're just strictly doing catheter-directed thrombolysis. A lot of us have migrated to other mechanical techniques. You're going to hear about that from Aki in a minute. So there are studies, and there aren't a lot of great modern-day randomized controlled studies, but here's what we have. This was sort of the initial experience from Parikh out in Washington, and basically they had mixed disease of both acute and chronic, but they saw a complete lysis in 70% of their patients. And that had not been the case where you use standard catheter-directed thrombolysis to date. Median infusion times were, as you see, in overnight thrombolysis with a relatively low complication rate. And then, a lot of times when we're looking at what's out there for the DVT and just catheter-directed thrombolysis literature, you heard earlier about the KVEN trial, We have the ATTRACT trial. You have the National Venous Registry, which is where a lot of these DVTs went in. And when you looked at it and lined this up at that time, you were looking at, shorter infusion times and less bleeding complications when using the Echos device. This study from Engelberger came out of Europe, basically looked at a fixed dose, which are very big into these fixed dose, low dose ultrasound assisted thrombolysis. And again, they had about 70 to 80% successful lysis and a relatively low bleeding complication. You can see the primary and secondary patency rates were very high, and they had pretty liberal use of venous stents and adjuvant therapy in this. So, and then one more study here looked at their single site retrospective data review of ultrasound-assisted thrombolysis versus CDT, and you could see that in this group, the lysis rates were more complete in the Echos device, using Echos over ultrasound-assisted. This came out of Miami. This was a retrospective review, just to give you sort of the counterpoint, a retrospective review of theirs. Again, there were a lot of different treatment regimens, and here they found no difference in Echos versus standard CDT. And then this is another European trial, one often quoted, which basically is called the Bermuda trial, and this showed no difference in the between Echos and standard CDT. Now, the one interesting thing here is they decided to stop all lysis at 15 hours and look at how much clot was dissolved. And so when you looked at that one formula, at 15 hours, there was no difference. A lot of critics of the trial would say is, well, what if you just completed lysis and saw whether or not there was, more complete lysis in one group or another? But this was the one that they used. And then the other thing is in the Echos group, there was a lot less adjuvant therapy. So nonetheless, that's what we have. So here, just a couple cases to illustrate the point. Patients of mine, excuse me, 27-year-old athlete, factor V Leiden gene mutation, comes in with acute right lower extremity pain and swelling. Leg was pretty tense. He had extensive iliofemoral, pop, and calf vein DVT. Started on unfractionated heparin, and as you should, and as I think you heard before, the patients are treated with anticoagulation in some regimen to see how they're going to do before you just jump straight into doing catheter-directed therapy. And here you could see occlusive thrombus here in the popliteal vein, going all the way up to the femoral, going all the way up into the iliac here. And so we placed the standard 50-centimeter infusion catheter and plugged them in with the protocol as I just stated. Here, 50-centimeter catheter, TPA at 0.5 milligram an hour. He had 16-hour infusion, and basically this was overnight thrombolysis catheter check. And actually in him, no adjuvant therapy, stenting or otherwise, was needed. And we've seen him now, 5 years out, and he's doing really well. Because again, if you're going to have a venous practice, you need to follow these patients, and that's probably another important take-home message. Second patient, 60-year-old, severe left lower extremity pain and swelling following a transatlantic flight. Venous duplex at the outpatient office showed left femoral vein DVT. She was started on Xarelto, and then the symptoms worsened at 7 days. Another take-home message from how we should be treating these patients is to evaluate them on anticoagulation and see who's going to declare themselves as either getting better or who's not, regardless of therapy. So we repeated the venous Doppler, and you now see that there was pretty extensive thrombus. Now, it was not just femoral and below, it was extensive thrombus now going into the iliac, and we always, for venous duplex ultrasound, look at the contralateral, and now there was continuous flow. So we don't have the time to take a poll, but that tells you something's going on up higher. And you can see here's the iliac vein thrombus, and why is there continuous flow in the contralateral vein? Because there's thrombus in the IVC. And so here we placed a 50-centimeter infusion catheter, same regimen, and here's following overnight lysis, and we find the underlying central venous occlusion of the left iliac vein, treated with successful stenting. So, in summary, ultrasound-assisted thrombolysis may result in higher rates of thrombus clearance and clinical improvement. It has been our experience. And this would then turn into lower dose and shorter duration. There may be higher rates of complete thrombolysis with Echos device. Data is conflicting, as you can see. I showed you no perfect trial to date, and I don't know if we will get that. But as with many things, it would be great if we saw a more randomized, controlled trial with acute DVT. Thank you.